there is no such thing as a free ACL graft, and this new paper proves why. I'm back. Looks like Adidas are back as well. I'm back in sunny London, having been teaching and speaking in Brussels and Barcelona in time for the Sunday paper roundup, where I read the papers so you don't have to. Today's paper is from Knee Surgery, Sports Traumatology, Arthroscopy, aka KESTA, and asks an important and increasingly relevant question: does ACL graft choice, hamstring versus quadriceps tendon, affect long-term thigh muscle strength and morphology after ACL reconstruction? Let's break it down. What do? This was a comparative cohort study evaluating patients who underwent ACL reconstruction using hamstring tendon graft and quadriceps tendon graft. They assessed isokinetic strength testing, thigh muscle morphology, strength symmetry, muscle deficits at follow-up, and the aim to determine whether graft harvest has lasting consequences on donor site muscle performance. What did they find? Well, in summary, hamstring graft patients demonstrated persistent hamstring strength deficits, and quads tendon graft patients demonstrated quadriceps tendon deficits. Not surprising, but here's the nuance. The deficits were measurable and persisted at follow-up, suggesting that donor site morbidity is not trivial. Muscle morphology analysis supported the functional findings. In other words, graft harvest leaves a footprint. Why does this matter? Well, we often debate graft failure rates, we talk about re-rupture percentages, but we talk less about long-term muscle balance, persistent asymmetry, and athletic performance implications. For athletes, this matters. For rehab programming, this matters. And for graft selection counselling that we do as surgeons, this matters. So now let's look at the critical analysis. Let's break it down properly. The strengths were that there was objective isokinetic testing, there was morphological assessment, not just functional scores, there was a direct graft comparison, and clinically relevant outcome measures. This moves beyond PROMs or patient-related outcome measures into performance metrics, and that's valuable. What about the limitations? Well, it was an observational design, there was no randomization, and there was potential selection bias in graft allocation. Rehab protocols may not have been fully standardized. We don't actually know whether deficits were clinically meaningful in performance terms, and there was no correlation with the return to sport level or injury recurrence. And importantly, strength deficits do not automatically equal functional limitation, so we must be careful not to over-interpret surrogate markers. What does this mean clinically? Well, it reinforces something we already know intuitively. There is no such thing as a free ACL graft. For a hamstring graft, expect hamstring deficits and be intentional with a posterior chain rehab. And for quads tendon graft, expect quads deficits and double down on quad recovery. That's where we talk about BFR, electrical muscle stimulation, all these other various modalities. Proprioception comes into it really importantly as well if you follow all my other posts. This paper does not say that one graft is superior. It says graft choice influences muscle recovery profile, which should then in turn inform patient counselling, rehab emphasis, and athlete-specific decision-making. So what's my verdict? Should you ignore it? Should you be aware of it? Should you consider it? Or should you use this paper and go right ahead and change your practice? Well, I say, be aware of it when you see a patient. This is not practice changing. It does not redefine graft hierarchy, but it strengthens the argument for individualised graft choice and individualised rehabilitation, and it reminds us that donor site morbidity is real and measurable. Stay tuned for next Sunday's paper roundup. I'll keep breaking down the evidence as it lands.